Good evening, everyone. Good evening, everyone. All right. We're almost there. We're at about 70%. Good evening, everyone. We just want to welcome everyone to this evening's event. So just want to say, first off, thank you for everyone coming out to our annual opioid settlement community meeting. So thank you guys for coming out and joining us as we begin to share what we're doing, all the exciting things that we're doing across the opioid settlement. So very, very excited. My name is Jason Smith. For those of you guys who do not know, I serve as the opioid settlement program manager. Very, very excited. So before we get started today, just a few housekeeping rules. If you guys, as you guys were coming in, you guys have bypassed the bathroom. So if you are looking for the bathroom at a given time, it is straight out these doors and to your right. Secondly, there are resources on the table. So please make sure that you grab some of the resources that are available there. They've been provided and worked on. So please feel free to go grab some resources on your way in and or your way out. Thirdly, and the most important, this is the input session. So we really are here to hear your feedback, hear in the voice of the community, hear what you guys, your opinions and things of that nature across the settlement and how things are working out on our end as well. So one of the major emphasis is really just getting your feedback, and you can give your feedback in two ways. There's going to be a QR code that you're going to see a few times. That'll be there. We'll also dramatically pause so you can see the QR code and make sure you guys can have that locked in your phone. But for those who don't utilize QR codes, and if you're like my father, and he's like, "Can you help me with my phone and get this thing right here?" We do have print surveys as well. All right, so we do have plenty of print surveys. So if you like to have a print survey in one way or the other, Giovanna, she has them in the back. Giovanna has her hand raised. She does have print surveys as well, and she'll be more than glad to get that, guys, to you. So for this evening, so I don't belabor the time, we're going to have 4 presentations that'll cover 5 strategies. All right, 4 presentations that will cover 5 strategies, and that's what we see here. We'll hear about the funds overview and the collaborative strategic planning. That'll be myself, and also John Paul Zitta is going to join me as well as a part of that session there. And then we're going to hear from strategy 2 and 3, and that's going to be Dennis Hamlet and Morgan Culver. We'll get to hear all the exciting work that's happening there. And then we're going to move into recovery support services, also known as the CLC Peer Support Program. That'll be by Lacey Schofield. And also, last but certainly not least, it'll be strategy 5. That'll be our post-overdose response team, our port team. We have Helen Tripp here and Dr. Joyner, so we're super excited about what we're doing with the opioid settlement funds. So moving forward, here we go. All right, so let's go ahead and jump into the first one. Strategy number 1 is going to be collaborative strategic planning. This is actually going to be the strategy that I operate under, and so I get the opportunity to have the inaugural position of being the opioid settlement manager, and I had the big task of doing the collaborative strategic planning. That entails not just having a structured process, but also to make sure that we have some long-term thinking around the settlement and to ensure that we are doing that correctly. So let me stop. I know you guys are looking at the QR code there. So make sure you go ahead and get your cameras out. Make sure you lock that in. There'll be a few other opportunities to be able to lock in if need be. But you'll see on that'll actually cover the entire session. So once you have that locked into your phone, you can hold that, take notes as you listen throughout the sessions. You'll be able to give your input via the QR code. If you miss it right now, don't worry, it'll be up again. Okay. So the opioid settlement. So for many of you guys hopefully have seen this payment schedule time and time again. But for those of you that have not seen this before, this is our 18-year payment that Durham County is receiving in regards to the opioid settlement. So we are seeing close to $21 million. And at an annualized basis, we're looking at spending around $1.3 to $1.4 million per year. All right. Now, these funds that we are receiving for Durham County, it does come along with very strict guidance, and we are guided by my document called the NCMOA, which is just the Memorandum of Agreement. So it really helps to guide us how we spend it. He's pretty meticulous on around these funds. So one of the major things that we're looking to do is provide transparency and accountability, and I'll show you what we're doing in regards to that. So a lot of times people see all this money and they say, wow, that's a lot of money. But at the end of the day, you can see how it kind of staggers in, how in the early years, how the funding came in, and how you can see how it's also begins to decline throughout those years that are forthcoming. Also, you also note too in the first couple of years as well, that we've had at least 3 years worth of funding that has come to increase. We have not spent those funds all just yet. We are really in the beginning stages of actually spending our funds. And so this year we'll see probably the most we've been able to spend these funds with the strategy so far. And you can stop me at any given time if you have any questions. All right, so how can these funds be spent? So usually a very common question that people typically ask how they can be spent. So it may support programs and services or people with OUD or substance use disorder or co-occurring substance use disorder. But really the main takeaway from this slide is that we have high impact strategies that we are able to spend these funds on. There are 12 to be exact. And I have a slide that kind of will show all those. The Exhibit B strategies, as you can see, there's 100 strategies in which we can also spend these funds. But here's the trick. Here's the big thing with Exhibit B strategies. Those cannot be, I'm gonna use the word unlocked until the collaborative strategic planning process is actually done through Exhibit A. All right. So the initial way that we can utilize these funds will be through the 12 high impact strategies. Okay. These are going to be like you can kind of jump into it and kind of just do the core aspects of us fighting the overdose crisis. Okay. So once we are able to get through the collaborative strategic planning process, which will be done by the advisory committee, we'll be able to work through that process. And once we're able to do that, we'll be able to enter into some more fine-tuned different strategies as well. Yes. Where are we on that advisory committee? Absolutely, that's a wonderful question. So where are we at with the advisory committee? We had just submitted the resolution. So essentially, we're trying to get it established now, and we are in the processes. Hopefully, in the next week, we will get some sort of approval around that. And so once we receive approval, the next phase of that, there will be a 30-day open application phase, okay, for that advisory committee. There'll be a 30-day open application phase for that. I'm sorry. Keep going. Last fall that I submitted an application for that. Are those applications defunct now and you're opening up more applications for the advisory committee? That's potential. I have to look into that. I came on board in August, and I could definitely look in there. And if there's anyone else who wants to speak to that, feel free to. Oh, that was the interest form. Yes. So yes, that was an interest form that people had received for those that were interested in the advisory committee. Yes. So is that yes. That is not the formal application. That would have to be provided through the county. For that, and it would have to be in an open, transparent way. But yes, great question. So what we did early on was we tried to garner as much interest as possible for those that might want to be on the advisory committee. One of the things that we've been doing, it's been taking quite a while to do, is build infrastructure around this advisory committee. And so that's one thing. Yes, question over here. Gotcha. All right. Good questions. All right, I'm gonna keep going here. Here are the 12 high impact strategies that I mentioned before. You guys can read through here, but essentially we're covering both prevention, treatment, and recovery. But once again, these are gonna be the 12 strategies. Those that are bolded are the ones that you're hearing about today. So that way you kind of can get a sense of what we're currently working on, which is the collaborative strategic planning, naloxone, port, syringe service program, and recovery support services. Yes, ma'am. Can you speak to how these were selected? Because some of these have very strong evidence base behind them, and there is no evidence base behind those overdose response. So I'm curious as to why that's something that comes. Yeah, it's a good question. I think one of the things was the already existing infrastructure that was in place. Once again, this was prior to my time, but there were some things that were already, the work was kind of already being done and the infrastructure was already in place. And one of the strong emphasis was to get the funds rolling and out the door. And so we were essentially looking for those that already had that capacity. And I believe that was kind of the early decisions on how those choices were made. It's a good question. Yeah, I can't speak to that initial one. I will. I can speak to how we're doing, how we're developing the advisor committee, in which does include people with living or lived experience. Absolutely. Yes. Hold on a second. We're gonna get you a microphone so they can hear you online.
Hi. How did we come up with the different strategies? Well, with Core and C, you have a list of strategies that you're able to pick from, and we have to go by those strategies, right? So, like Jason stated, some of the programming that we were doing within the county and outside of the county, the infrastructure was already there. So, in order to get the funds to the community, because that's what this opioid funding is for, we decided, not me, but we all decided, since we have these strategies, we know that they're working and they are evidence-based, we decided to go ahead and utilize these strategies. However, once the board come on, we don't know, whenever, however they decide, if they want to do different strategies, or if the community, because that's why we're having these input sessions, you tell us what you all want to see, and that's how we move forward, if that makes sense.
Excellent. Excellent. All right. So one of the things I'm just going to jump into, and I'm going to ask John Paul Zeta, if you want to come join me here. One of the things that we're doing with the collaborative strategic planning is just having some strategic partnerships. I've already mentioned too, just around the advisor committee that we already are working and getting established. But one of the other things that we're very proud of that we were able to do is have a front-facing dashboard that we are working towards. And I am going to turn the mic over to John Paul Zeta so he can do a live demo of the dashboard that we're currently working towards.
Thanks, Alicia and Jason. I'll wait for you for a moment. Yeah, so who I am, I'm John Paul. Do you want to swap over? I'm John Paul. I've been working in public health for almost a decade. Not in public health specifically, in Durham County for almost a decade. Been here for a little over 4 years. Started in the middle of COVID. So we've built a lot of different dashboards, and we've actually integrated a lot of different insights into building this through lived experience and how we want to integrate and share this information to the community. So this is actually really exciting for me because this is the first time more than Jason's or I's eyes have actually been available to see this data. So collectively, we have to produce information, collect it, break it down by quarter, by month if available. There's a lot of data that is collected by Morgan and Dennis's team, and I really appreciate all the work they've done. So what we have here is our first information about vending machines. So we're looking through the distribution of the data. So we're starting at the beginning of the fiscal year, and we're starting in July. And we're looking at overall distribution and how many are being taken from the vending machines that are free. They're sitting at the front of public health building, and right after you enter or as you're exiting, you can come in and you can go in free of charge and gather some Narcan for yourself if you'd like. There's also a location at the sheriff's office where you can do that as well, shown in green. So you can see the total number distribution throughout the full year. The public health numbers are the way they are due to the, I think, ease of access and the opportunity in which how often we actually track this data and how frequent we are in restocking and availability for everyone. So if you don't mind going to trend data, remember control click. Perfect. So we're looking at the overall differences throughout the fiscal year, and we're comparing it to previous quarters. That's how we're just kind of generating this already. But what we want to do over the years is actually do a year-over-year analysis, so we can actually integrate and see our trends from that data. So we'll go down to harm reduction CLC program. There's a lot of data that we collect, and it comes from all the hard work that everyone does throughout all of the programs. So with the harm reduction right here, we can see that these are some of the metrics that we're pulling in. If you were to click on any of those months, it would actually pull some of that data, and it would pull all of the data and translate all to just that information. It takes a little bit, but you can see where all of the graphs highlight and deselect based off of that. So if you don't mind going to syringe. Thank you. Again, more or less the exact same thing, but it's the bringing the data to alive. It's making it alive. It's showing us the actual insights instead of just looking at it on a flat Excel sheet. You're able to kind of visualize this information. You're able to see things go up and to the right. That's a good indication of where we're seeing our trends. We want to see more dispersal, more engagement, and that's kind of how we're working through this information. Go to recovery. Yes, sir.
This is super minor, and this doesn't really matter.
Okay.
Narcan technically means like one brand.
Okay.
And naloxone is the generic, and I know that y'all distribute mostly just a generic 4 milligram naloxone. So whenever I notice Narcan, I just we do it's one specific brand.
And that's good. That I appreciate that kind of feedback, because that's not stuff that I'm privy to. So I appreciate that kind of feedback for normalizing language.
Absolutely.
So the recovery support services, this is more of our data from those. And then we have a harm reduction map where we have input this information. And this being the first edition of this, is I've already communicated with Morgan, and she shared a lot of really high quality information that I think will actually elevate this more. She does an incredible amount of work, and a lot of it's not being displayed here just because of the lack of access and the inability of me knowing all the program. And as I'm learning this stuff, I'm going, okay, I need to talk to this person. We need to engage. We need to understand how we can demonstrate this to the public. So I'm really excited to be able to work with Morgan in a few weeks to kind of elevate this again and push it out, and so that we can really do a specific notion, and also show all the hard work that she does and be able to communicate how important all of this is. So if you go to emergency services. Again, this is high level data, but we don't have so much that we can start displaying it in a very granular fashion. We may be able to over the years, but the intent is just to show publicly what we're looking at. So these are all just generic data points that we've captured. We're looking at the total Narcan used in treatment for those that where it was used, and we can see the total breakdown by hour of day. It's in the 24-hour schema. You can also see, was naloxone used more than once for that patient? You can see a yes, no. You can see the left tail when you have your age breakdown by the EMS. So there's a lot of insight here by when you just look at it at a flat table, you can't really discern that. Just having these simple little graphs to kind of communicate that can kind of help drive your engagement. It can help drive how you want to approach the problems. If you want to go to EMS incident map. Thank you. It might take a little bit to load, but again, this is just a generic overview of our EMS incidents, and it's probably going to maybe work. Okay, didn't quite work. Close enough. Oh, it did work. Great. So again, this is zip code level. We are allowed to share this data at the census tract level, but we have to suppress it at the current rate because we only have a quarter's worth of data. Now, when we have 10 years worth of data or even a year's worth of data, I'll probably be able to start showing a heat map or breakdowns of, okay, we have hotspots here. This is how we need to approach those things, and really work with all of the hardworking people within this department to really engage everyone outward. So toxicology data. Thank you. So before I go into this, I do want to show the state does an excellent job of sharing all of our data, and they do it in PDFs. The PDFs, there's those 3 PDFs at the bottom. No worries. Thank you. Any of those 3. Right. So these are lovely, and they communicate an incredible amount of data. So there's a lot of different graphs and a lot of different issues in what they're communicating throughout all three of these. So you can just click through them real quickly. One of the, just the first thing that we did was we imputed this data, we understood it, and we tried to we iterated on it. We tried to make it so that it was a little bit more digestible. So if you can go back to the dashboard. I just kind of wanted to show what it looked like. So what we did was we consolidated all of those 3 pages of data down to a couple simple graphs that explains the exact same amount of information. It's just a little bit more easier to compute and a little bit easier to understand what's going on in Durham County. So you can go to trend data. Again, the intent is, and it's very hard to see, or at least for me, my eyes are terrible, is the percentages under in green. You can see the minus 36% in relation to the last quarter. And I think being able to see that data and really understand all of these things year over year is really going to give us a lot of insight. So that's kind of all we have right now. You're going to hear more about the opioid settlement funds than you already have. But once we get that set up, we'll make that publicly available, and we're going to continue to add pages. I know I'm going to add a bunch with Morgan, and just to showcase all of our work. Like, just for example, demonstrating how much xylazine strips, the different kinds of, I'm blanking obviously because I thought about it like right now, but the xylazine strips and all the other strips and work that she does is not being communicated. So it's going to be great to be able to see all of that. And that's kind of all I have.
If there are no other questions, we'll ask Dennis Hamlet and Morgan to come up next for the next presentation. You're trying to fix the mic.
Yeah, I was gonna use that one, so I'm not like.
Okay. Yeah,
That's okay, I can just do that. We're
Okay.
good, y'all keep that one. Yeah.
Okay.
Yeah.
All right. I'll start.
Yeah.
Okay, cool. All right. Good evening. Good evening. My name is Dennis Hamlet. I serve as the Communicable Disease and Harm Reduction Program Manager in our Health Education Division at the Durham County Department of Public Health. I've been with the county since 2013, and I've had the opportunity to coordinate and lead some of our health education programming focused on HIV and STI prevention, maternal and child health, and our opiate response efforts.
Good evening, everybody. My name is Morgan Culver. I'm the harm reduction coordinator on Dennis's team with Durham County Public Health. I have been in this role since August of last year, but I've been a Durham County resident for 7 or 8 years, and I've worked in harm reduction and public health for almost 10 years.
Sweet,
Happy
sweet.
to be here. I'm excited to talk to you all about our program.
Awesome. Given that we're conducting this presentation in tandem, we'd like to respectfully request that questions to be held until the end of the presentation. All right. Next slide, please. Oh, I got a clicker. Got it. All right, great. So Durham Public Health, we've been implementing our harm reduction work since 2018, beginning with our safer syringe program and our community-based naloxone distribution program. These functions were primarily conducted through our Durham County Pharmacy, as well as our Health Education Division. In 2023, with the use of county funds, we were able to launch our naloxone vending machine, which afforded us the opportunity to have 2 vending machines, one being placed at our Health and Human Services facility, which is available during business hours, and vending machine number 2, which is located at the Durham County Detention Center, which is available 24/7. Thanks to opiate settlement funds, we were able to expand our impact. One key change was able to hire a public health education specialist. Previously, our work was conducted across teams as a collective approach, but now that we have one sole subject matter expert who's able to focus on the work, but still has the ability to lean on a strong team infrastructure. Next slide, please. Got a clicker, sorry. All right. So in addition to our safer syringe program and our community naloxone distribution program, thanks to opiate settlement funds, we've been able to expand our approach by providing comprehensive harm reduction education and training. These trainings can be conducted in person and virtually. All right. We offer these trainings to community-based organizations, community members, and businesses.
These three core program goals ties into our overarching goals for the program. So number one, we want to reduce the occurrence of fatal and non-fatal overdoses here in Durham County. How do we do that? Saturation of naloxone, as well as providing overdose prevention education. Goal two, we want to reduce the occurrence of HIV, Hep C, and other infectious diseases. So we do this by providing safer use supplies, providing education, and testing. Additionally, we want to empower and increase knowledge of community members to reduce the harms associated related to substance use. And finally, most importantly, we want to be able to connect community members to low access services such as treatment, mental health, housing resources, and other social services. When we conceptualized our harm reduction program, we felt that it was imperative that we had a framework and guided principles to drive our work. We didn't want to do work randomly. We didn't want to do things on a personal whim or arbitrarily. So we wanted to set a foundation so that our work is done in a value-driven framework. So we're going to start with data-driven. Now that I give you the framework, I'm going to cover some of the core frameworks that we use. So of course, it's important that we're data-driven. Being data-driven really sets the tone for our work. Everything that we do within our harm reduction strategy, from our naloxone distribution program to our SSP program, is proven effective as well as being evidence-based. It's also imperative that we have an interdisciplinary collaboration, also known as collective impact. Everyone a part of our core and expanded team consists of health educators, harm reductionists, data scientists, epidemiologists, first responders, and individuals with lived experiences. All these individuals in their expertise and their subject matter expertise are able to come together to guide and impact our work. It's also important to be agile and adaptive. We've been doing this work for a while. However, within our first year of receiving opioid settlement funds, we must be responsive to reoccurring needs, as well as being able to prime ourselves to respond to emerging needs as well. And finally, we have to approach this work with a syndemic approach. We have to understand that harm reduction and substance use intersects with other public health challenges, such as mental health, housing, poverty, and HIV and Hep C transmission. So here's a quick summary of how we spent our $342,000 for fiscal year 25. Most of our funds were used to provide direct services. Our largest operational expenditure came in the form of medical supplies, which is primarily driven by the purchase of naloxone. In fiscal year 25, we were able to purchase 3,200 cartons of Narcan, which effectively is 6,400 doses of the life-saving medication. Harm reduction supplies accounts for 13% of our operational expenses, or actually our total budget. And fortunately, harm reduction supplies such as syringes, fentanyl, and xylazine testing strips are pretty low cost, which makes them excellent tools for prevention.
I'm going to try this mic. Is this working? Okay. You got my clicker?
Yep.
Awesome. Perfect. Great team. Okay. All right. Hello again, everybody. My name is Morgan. And now that Dennis has given us a nice overview of our harm reduction program and what we've done in the last year, I'm going to give us a little bit more detail about those 3 areas of focus that our program has. So to start, a quick refresher. We've already said the phrase harm reduction a million times, but just for anyone who might be unaware or needs a refresher, I want everybody to know what we're talking about here when we talk about harm reduction. Most importantly, harm reduction is a movement and a philosophy that centers the human rights of people who use drugs, right? We all have things that we deserve and that we need to thrive, and engaging in the behavior of substance use doesn't change that. So that's where harm reduction comes from. What harm reduction actually looks like in practice is a set of evidence-based tools and interventions that are aimed at reducing negative outcomes associated with drug use. So that's what we mean when we talk about harm reduction. All right, so like Dennis said, we have these 3 areas of focus on our program. First is our Safe Syringe program. I love this little button. The point is to save lives. That's a pun for y'all. I hope you enjoy it. So the reason that we do Safe Syringe or syringe exchange, as you might have heard it referred to, is that we have about 30 years of data that tells us that Safe Syringe programs are proven to save lives and improve health outcomes. Like Dennis already said, this program aims to prevent disease transmission for viral hepatitis, HIV, things like that. We want to prevent overdose and injury, overdose, injury, and death, of course, with naloxone. And we also want to bridge people to medical and social services. And SSPs serve a really important purpose in that they are a landing point for a lot of people who are not engaged in any other services. And so people who use drugs, who are engaged with an SSP, with a program like ours or the wonderful Harm Reduction Coalition, we're very lucky to have in Durham. Folks who use drugs who are engaged in those programs are way more likely to access other social and medical services, including treatment. So, like Dennis said, we have had our Safe Syringe program at Durham County Public Health since 2018. And until last year, primarily the way that participants could access that service was by coming into the health department up the street, going to our pharmacy during selected hours. I think it's like a total of 12 hours a week, something like that, that we're open for that. But that comes with a lot of barriers, right? For anyone who has been in our building, it's beautiful, but it's a big, scary government building. You have to walk through a metal detector and talk to people with badges on to get in there. And also there's other barriers like transportation, all kinds of things that make it difficult for everybody to access this great service that we have, right? So in an effort to try and circumvent some of these barriers and overcome them, with our settlement funds for this program starting in August of last year, so a little under a year now, we have put a lot of effort into expanding the availability of this program. And the way that we do that is that we now offer direct outreach and mobile delivery. So what that means is that I have a work cell phone that I try to share as broadly as possible. And anybody who uses drugs, whether they're a part of our program already or not, can reach out to me and say, hey, I need syringes, I need waters, I need Narcan, whatever. And I will go to their house, I'll meet them at the Wendy's, really whatever works, right? And then we also do SSB outreach at different events where we know people who use drugs are already going to be accessing other services. And that has led to a lot of growth for our program. Offering those two things in the last 10 months or so, we've registered over 40 new participants, which might sound like a low number, but just for reference, our pharmacy walk-in syringe exchange sees about a dozen regulars, right? So 40 is a lot of growth for us, right? And we're growing all the time. We're getting more people. Another huge win that we had with this strategy with offering, physically taking our syringe exchange to where people already are is that we gave out twice as many syringes in the last 10 months as we usually do. So that's exciting as well. In addition to expanding how people can get our services, we also offer a broader range of supplies. So usually people think of the syringes, which is a really big one, but now with more funding, we're able to offer people hygiene materials, more drug checking supplies with more comprehensive stuff in the kit that they need. And we also now have supplies for other methods of drug use. So it's more inclusive to other people who might use drugs but don't inject drugs and that kind of thing. We also are no longer rationing expensive supplies, which is huge because in order for harm reduction practices to work, people need a lot of supplies. They need a new, there's all these little pieces of equipment that people need, and they need a new one every time they use drugs. And for some people, that's many times a day. And so rationing supplies just lowers the efficacy of the program. So we don't have to do that anymore, which is really great. Thank you. Okay, we can go to the next one. Okay, number two, the second thing that's under the scope of our program is our community naloxone distribution. This is a priority for a couple different reasons. Like Lofton said earlier, naloxone is the generic name of the medication that you might have heard called Narcan, which is just a brand name. Part of the reason that we want to distribute lots of naloxone broadly in our community is that unfortunately we're at a place now that about 42% of American adults personally know someone who's died of overdose. So that's more, it's a little less than half of us who are sitting in here. And so unfortunately, a lot more people may witness an overdose, and we want them to be prepared for that. So that's a big part of it. Oh wait, can we go back just for one sec? The other really big and important reason that we focus on community naloxone distribution, like Dennis said, is that communities that have a higher saturation of naloxone, the more naloxone kits that are out there with more people, there are fewer overdose deaths and there's less drug use overall. So that is the main reason why we do this. Okay. All right. So like Dennis said, we've had naloxone programs for a couple of years now. Since 2018, when our SSP started, our syringe exchange, people could come into the pharmacy to get naloxone on a prescription basis. And they're also, the health education team had a kind of small scale naloxone distribution as well that we would kind of get ad hoc and be able to share with people whenever we had it. And then, as we mentioned, in fall of 2023, we got our 2 gleaming, beautiful, free naloxone vending machines. And at the time, we didn't have the funding to keep them filled. We were, again, rationing those supplies, and harm reduction doesn't work as well when you have to ration. So thankfully, they get filled and it empties, and I am excited when I have to fill it every couple days. All right, so starting in August of last year, again, when we had this expansion of the program, we now are able to do much broader distribution through a couple different methods, one of which is we still have our vending machines and we're getting more, which is exciting. We also do a lot more outreach now that we have me, a designated staff person, to do street outreach, event outreach, all kinds of stuff. And then a really big one that we're really grateful to have and has brought us a lot of progress is that we now distribute naloxone through about 15 community partners. These community partners are, nonprofit organizations, community-based organizations. We have a couple businesses. You saw, maybe some of you caught on JP's list. We have a couple barbershops. Anywhere that people who use drugs are already going is a place that we want them to be able to get naloxone, right? And because we've been able to distribute through all of these different methods, in the last 10 months, we've given out more than 3,400 naloxone kits, which is very exciting. We're very proud of that. If you remember from the last slide, it was 650 over 6 years. So we're really going for it now, which is really exciting. Okay, I wanted to throw this up here very quickly. If anyone's curious to see where all of the naloxone that we distribute goes, the biggest amount that we give out goes out through our 2 vending machines, health department and detention center. We also give out quite a few through our community-based organizations. And then that part at the top, other partners, includes things like businesses, a couple medical clinics, stuff like that. And then these smaller pieces on the left is all of the things like our trainings that we do, which we'll talk about in a second, events, and then our SSP distribution. And it's also worth knowing that that amount of naloxone that goes out through our SSP might look very small, but because folks who come in to see us at the pharmacy are usually grabbing it from the machine, some of that's probably in there. Okay. The last thing that we do into this program is our harm reduction education efforts. And the reason that we do this is because we want individuals who use drugs to have information so that they're able to make decisions and do drugs in a safer way. That's a big part of what harm reduction is and how it works. You can have the supplies, but you have to know how to use them too. And then we also want to put a lot of effort into increasing community awareness of what harm reduction is, what harm reduction resources are available to people, because we want more referrals. We want more people to know that we're there and to come use our program. Also, because we have done so well to give out so much naloxone, that means there's a lot more people who need to know how to use it. And a lot of folks find it helpful to learn from another person and not just read it on the back of the box, which you can also do. Okay. So a quick shameless plug before I talk about everything else on the slide. If you want me to come do a harm reduction, naloxone, sharp safety, any kind of training for your organization, you can scan that and fill out the form that pops up. So since this program expanded last year in the fall, we've been able to start offering free harm reduction trainings to any interest or organization. We get requests from businesses, nonprofits. I just did one at a church last night, your mom's book club, anybody who is a group of people who want to learn how to do this. I would love to come and teach them about harm reduction and how to use Narcan, naloxone. In the last 10 months, through offering this, we've done 13 trainings and we've trained more than 200 people, which is really exciting and is growing all the time. I get new requests and it's one of my favorite parts of my job. So please don't be shy. If you want this, please request it. Okay, very quickly, I wanted to add a couple highlights that didn't really fit into any of those because these are a couple other things that the program has also done in the last year, this fiscal year, that we're really proud of, that we wanted to shout out. One of which is that we are very lucky and have gotten to collaborate with City of Durham Community Safety's HEART program. We've done a bunch of trainings with them and some technical assistance. And next year, after July, we're very excited that we are going to essentially add the HEART team as an extension of our Safe Syringe program. So when the HEART team goes out on a call, if the person that they're working with uses drugs or might benefit from our SSP, they're going to be able to operate as kind of like an extension of us. So that's really exciting. Some other big things, we've been very lucky and have gotten to work with the wonderful folks at the Harm Reduction Coalition who have a wonderful wound care program. We've been able to support them with some supplies and stuff like that. We also have a couple spots where we've been really successful doing outreach and getting new participants and giving out a lot of supplies, like at Open Table Ministries Free Store, the Fresh Start Free Shower Program, stuff like that. And then something else nice that's happened is that we've just kind of organically have a couple folks who are part of our program who do peer distribution. So if they have friends or family members who can't come and see us, they're able to get enough supplies that the folks that they care about can use everything too. It's better.
Take the mic so I have to stand awkwardly on the
I
podium.
know, I didn't want her.
All right, so for goals for fiscal year 26, we have some ambitious yet feasible goals. I'm really proud to announce that we are expanding our team. Recruitment is underway for a full-time contracted harm reduction program specialist. The individual in this role will assist us with expanding our naloxone and safer distribution program, as well as providing some peer support resources. The overarching goal for that objective of the position is that we really want to strengthen the linkage between harm reduction and treatment services. Additionally, we are currently underway to acquire 2 more naloxone vending machines. So we'll have a total of 4 machines that are strategically placed across Durham County to expand our efforts. And finally, as JP alluded to earlier, we have a pretty robust data collection and program evaluation process. However, we do want to bolster it and continue to expand it. We want to begin to track key indicators. For instance, we really want to get an idea of how many naloxone kits are we distributing are actually being used to reverse overdoses here in Durham County. And given that it will be our second year using opioid settlement funds, we also wanted just to measure our impact and some of our outcome measures to see how well we're doing overall with the program. So I would be remiss not to acknowledge the key individuals who help plan and implement and support our work. I'd like to acknowledge our Health Director, Dr. Rodney Jenkins, our Deputy Health Directors, Christian Patterson and Liz Stevens. I'd like to give a shout out to our Health Education Division Director, Lindsay Bickersbach. I'd like to give thanks to our Medical Director, Dr. Jeff Jinks. He and I co-lead our Durham County Department of Public Health Opiate Response Committee. Additionally, I'd like to thank all the program areas who support our work, our Durham County Pharmacy, our Wellness and Promotion team within our Health Education Division, Population Health, JP and Savannah. I also want to give a special thanks to our admin and finance team. Coordinated and organized. I would also like to give thanks to our community partners and members, specifically our North Carolina Harm Reduction Coalition and the Durham Heart Program. They are our frequent and long-term collaborators. And finally, I would love to thank the Durham County leadership for their support, including our Durham County Manager and Durham County Commissioners. We're happy to take any questions.
So I would first just lift up some grace for the team. I worked with a lot of state and county governments on harm reduction with decosments.
I every day feel exceedingly privileged and lucky to be in a county with people who have such expertise and talent and compassion, and I want to weep and thank you. My question is about the naloxone distribution. You guys are doing really impressive work, and one of the questions I had though was about the procurement of nasal naloxone. So there's like a lot of reasons why nasal naloxone might be appropriate. Children, for example, or folks who have mobility issues, or where syringe access is a safety issue, like in our county jail, for instance. But intramuscular or injectable naloxone is an order of magnitude cheaper than nasal naloxone, which means that you can buy 10 times more with it. And we know that the evidence-based intervention, community access is important, but the evidence-based overdose prevention intervention is targeted distribution to people who use drugs, to people who are likely to be present for an overdose. And study after study after study indicates that those individuals, regardless of how they use drugs, tend to prefer injectable naloxone. So as one of the people you anticipated in the room who has lost a lot of folks to overdose, I'm curious to know if our county is going to be investing dollars in this like highly more affordable option that's often, I don't want to speak on behalf of anyone, but often more desirable to the folks most likely to use it.
Okay, so the question, if I understand you, is are we going to buy intramuscular naloxone in the future and not just nasal? For anyone who's not aware, so there's a bunch of free naloxone out there. That's all the nasal kind, you spray in somebody's nose. What Dr. Carroll's talking about is injectable naloxone, which you use an intramuscular needle to draw it from a vial and then inject into a person. We've talked about integrating that into our program, and I think we're hopeful to do so in the future. I think the hurdle that we have is maybe like some policy adjustment because we've only done nasal in the past. Is that right?
Yeah.
Anything else?
Yeah, and I'll just briefly add, we are aware about the other option for naloxone, and we're also aware that we could potentially offer 3 milligram doses of naloxone as well. So we are definitely exploring alternatives, but it's going to take an arduous process through policy modification and development. But we are aware and so in supportive of it.
Thanks for asking. That's good to know people want it. We want it. That's right. Question? Anybody?
Sweet.
Oh, thank you.
Thank you all so much. I'm so excited about the work you're doing. My question was, where are the 2 more vending machines going to be located?
That is the question of the evening. Dennis, do you want to take this one?
Yeah.
We're doing that too.
Yeah, so we've made provisions to procure them, and we have a lot of interest. It's just a matter of facilitating agreements. One potential candidate for the vending machine, which Morgan has thrived and done a really good job connecting, is Joseph Pharmacy, which is actually located in one of our priority zip codes, 27704. So we're, in discussions, and that's one of our plans for vending machine number 3. And if you all have any ideas or any suggestions, we're happy to take the feedback so we can move accordingly. But yes, 27704, 27707, and 27701 are our area codes of interest.
One thing to add. Thank you. One thing to add, something we're very excited about is the 2 vending machines that we have coming are both outdoor machines, are fitted to be outside and temperature controlled, because our hope is that it is going to be as smooth and low barrier as possible. In my dreams, people pull up, don't even turn their car off, hop out, grab it, and leave 24/7. Because like Dennis said, the one at the detention center is 24/7, but there's nowhere to park on that street, and we close at 5. So our hope is to have some a little bit better access there. Great question. Other questions? Okay, thank you so much.
Hello. Good evening, everyone. My name is Lacey Schofield. I'm also with Durham County Department of Public Health. Oh, you turned it off. Is it on now? Okay. Okay. Good evening. I'm Lacey Schofield, and I'm also with Durham County Department of Public Health. And I am the program coordinator for the Community Linkages to Care Peer Support Program, or abbreviated CLC program. Now, this is a program that's been going on for over 5 years. It was initially the brainchild of the Durham Joins Together to Save Lives Task Force, which is a multi-agency group that was started in 2018. One of the co-chairs is sitting right there, it's Commissioner Wendy Jacobs, and the group came together to all of the community organizations working on the issue of the opioid epidemic at the time. And so this program was workshopped in one of the committees. They identified a need for peer support, and they got together, all the groups involved, and they wrote a joint grant application, and they were awarded in 2019 a grant from the state, the North Carolina Department of Health and Human Services. So that was the start of the peer support program, and we operated on kind of a shoestring budget. And then the grant ended in about 2023, and that's when the opioid settlement funds came through, and we were awarded funds through that, and we were able to expand the program. So the program fits under the Option A strategy, recovery support services. And I've got the full description of what that strategy is as laid out for the opioid settlement funding. When it came out, I was really pleased to see that they would fund peer support programs, because that is the CLC program, and that they were looking to support programs that supported people in treatment recovery or people who use drugs. And you know, our program has always had a focus on people at highest risk for opioid overdose. It started out small, just focusing on that group, and we quickly expanded, and now we offer peer support services to anybody with any type of substance use disorder. And the reason is that anybody with substance use disorder is at risk for an opioid overdose. These days, the drug supply is very contaminated, and people don't often know what they're taking. So they may think that their sample is cocaine. For example, on the screen, this is an actual sample that was tested, and the yellow is cocaine, but you can see there's all sorts of other drugs in it, and the purple is fentanyl. So, you know, people don't always know what's in their drugs, or even if they were just taking cocaine, their next sample might have an opioid in it, and they would overdose. So we feel very strongly about enrolling anybody with any substance use disorder into this program. So we have 3 wonderful peer support specialists, the 3 on the top, that's Tony, Trina, and our newest, Savales. He just joined the program. We had a different peer support person for over a year, Keith, and he left the program recently, so we just hired Savales. And we love these guys. And Kim Chanson, who's also in the audience, she's their direct supervisor, and of course, I'm the program coordinator. Now, the peer support specialists are based at RI's Durham Recovery Response Center. And this is a behavioral health facility that's located right across the street from Duke Regional Hospital. And it's in the same building as the DRRC crisis unit, which is the only crisis unit in Durham. About 70% of the people who come in with a crisis have substance use disorder. So it's very convenient to have our peers right there, and they can meet with people coming in. So peer support specialists. Well, this is an evidence-based strategy. These are people with lived experience of either substance use or mental health disorder. As you can guess, you know, people that use drugs sometimes have a hard time trusting mental health professionals. They really relate to somebody who has lived experience, someone who's been there, understands what they're going for, and they can establish trust with these people. Studies show that peer support specialists increase the rate of engagement in recovery and lots of other benefits. Our peer support specialists all have completed a 40-hour basic training program, and they've been certified through the North Carolina Certified Peer Support Specialist Program. So on the left are some of the partners that we get referrals from. Our peer support specialists go out in the community and try to connect with people with substance use disorder at a variety of organizations. We work with both of the Duke hospitals. We get referrals from people who come into the ED with an overdose, and also people that are inpatient and that are hospitalized for complications from their substance use disorder. We work with the community paramedics and take referrals from their post-overdose response program. As I mentioned, the crisis unit. We also take people being released from the jail who have been identified with substance use disorder, a number of other organizations. And just this past FY25, we started a partnership with TROSA, and the people that are graduating TROSA and going out back into the community often have needs and need some extra support. So we even have a flyer that's tailored to TROSA graduates. And of course, we take walk-ins. And so on, everybody coming in gets connected to one of the 3 peer support specialists. On the right are all the things that we can help people with. Obviously, one of the most important goals is to get people into treatment. And our peers can make appointments at either to get treatment at either DRRC or at any other treatment facility in the county. But not everybody is ready for treatment, and that's okay. We want to meet people where they are. Sometimes people just need housing. They can't think about recovery until they've got housing or employment. And you have a question? It probably at the end, if that would be better. Well, actually, go ahead while it's on your mind. Yeah.
Are you involved with, or is it through the Durham County Detention Center, the Durham County drug treatment court that is occurring now? The criminal court system.
We're not involved with the court. Mostly the referrals are coming right after they're released from prison.
Is there a reason why is that part of the bylaws?
No, actually, that's a great idea. We're always looking for new places to find participants.
And how does one go about to look at?
Oh, please send me an email. I've got my my email address on the last slide. And I also give you a card after this. That would be awesome.
I may not be able to stay so late, but I'll look
Okay, yeah.
Thank you.
Welcome. So where was I? So we can help them find housing, employment. We've helped people find childcare. We've signed people up for Medicaid so that they can get their medication, all sorts of help that the peer support specialist can provide. So the first time, usually we get a referral, it's through a phone call or an email from our referring partners, and then our peer support specialists follow up, usually over the phone. Occasionally it'll be in person. For example, with the hospitals, we are approved for our peer support specialists to go into the hospital and meet with patients in their hospital room. So they can do that. And at the first visit, they will do a little bit of motivational interviewing. They'll assess their needs, and they'll give them a free naloxone kit and a packet of information that's just chock full of resources, including our wonderful resource guide, which there's a picture on the slide and I've got here. And also, I think Morgan brought a ton of extras if you want. We give these out in the community. And they have contact information for where people can get treatment, where they can get harm reduction, STI testing, everything's in there. We developed this actually with some funding from the CLC program, and we update it every year with a small portion of the budget. We also have them in Spanish. So we give them a packet of information, and then our peer support specialists will set up appointments for them for whatever they need. And if they want treatment, one of the biggest barriers is transportation. We have a portion of the budget that pays for Uber rides. So we actually provide an Uber ride to their treatment appointments and other appointments. In fact, we've driven people to drug court, I believe. Right, Ken? Yeah. So that is a really great part of the program. After the first phone call or the first visit, our peers will call them and check in with them. And they have the option to meet in person on a weekly basis where they can get support. The peers are trained to talk to them about their triggers and how to avoid them, and just kind of be there to walk with them through that journey of recovery. And then we also ask them to sign a consent form so that we can collect their data. And we collect it at baseline, 3 months, and 12 months. So now some of the data. The opioid settlement funding requires us to collect all sorts of data, and which is good because we've been doing this for 5 years. But I will say that not everybody wants to give their data to us. Not all of our 200 participants sign the consent form. It's really only about a fourth of them that sign the form. We definitely want to get their consent before we take information on their demographics and their substance use, which is very personal information. But of the consent forms that we've gotten, and I'll say that we have 5 years of data, but I've been asked just to present the data for this fiscal year. So from FY25 Q1 through Q3, we had 65% Black and 35% white participants, which is very encouraging because, as we've seen, rates of overdose are higher in the Black community in Durham than white communities. So we want to be taking in more Black community members into this program. 41% were men, 59% women, and they reported that they had opioid use issues in about 50%. But this is probably a really low underestimate because, as I said, not everybody knows what they're taking or really wants to admit what they're taking. So 50% is probably a lot lower than it really is. And the rest of them have some other form of substance use disorder. So in those 3 quarters, we reached 187 participants. Our peers connected and talked with and gave support to that many people. And we're estimating half, about 94, had opioid use issues. They had 2,767 total contacts. We're actually asked to keep track every week, every time our peers talk to somebody on the phone. I mean, this is where our peers really shine because they are just always talking to the people, being someone that the person can talk to, someone with a listening ear. And our participants actually call them sometimes multiple times a week. So then we've given out 51 naloxone kits, and we've provided 402 Uber rides in just those 3 quarters. So we also keep track of how many people decide to come to an in-person peer support appointment and how many people come in for treatment. So we had 152 people make an appointment for peer support and 104 people make an appointment for treatment, which is really great out of 187. That's a lot of people that maybe would never have gotten into treatment, and now they're in their treatment. 105 showed up to that first peer support appointment, and 75 showed up to that treatment appointment. So it's a 69% linkage to care for peer support and 72% linkage to care for treatment, which is really great. It wasn't this high always. We've worked really hard over the past 5 years to get that no-show rate down, because in this population, it's actually a pretty high no-show rate. There's transportation barriers, all sorts of barriers. We now give out incentives, gift cards for people that show up at their appointment. And so we've gotten that linkage to care rate up. And then finally, they want us to collect housing and employment statistics that we follow up people for 3 months. This is really hard to get because first the people have to sign the consent form, take the baseline survey, and then 3 months later we have to locate them again and then get them to take a 3-month survey. So I will say these are very low numbers, but out of all the people that were unhoused with opioid use issues when they started the program, we were in 3 months, about a quarter of them found housing. And same with employment. In 3 months, if they were unemployed, about a quarter of them found employment. And I think that's pretty good. As you know, right now there's a housing crisis in Durham. It's very hard to find housing, and sometimes people are on wait lists for 6 months. So for 3 months is pretty good. We work really hard at that. And then finally, satisfaction survey. For everyone that took the satisfaction survey, 100% said they were satisfied with services. And I'll just close with some participant quotes that you can read. Participants really love the program, and I especially love that first quote. I would say that the peer supporter helped save my life, and we hear that a lot. So there's my contact information and Kim's contact information. Questions? Yes.
I was wondering, so I was wondering, when y'all give out referrals or link folks to care, what's your process for like vetting those programs before you start sending folks? And then also kind of on the other side, I was just curious about if you ask people about like their referral experiences afterward, if you're all collecting data on that.
No, that's a good question. So because DRRC has a treatment program, there's a therapist, and they also prescribe buprenorphine there. Most of our participants have chosen to get their treatment there. And it's just great because our peers were right on the site, so they could have a friendly face. But if a lot of times they might want something closer to where they live. And really, it's kind of dependent on their insurance. Most of our people have Medicaid or they're uninsured. And we know the places that take uninsured or Medicaid people, basically Lincoln, Morris Clinics, BART, and a couple others. And that's sort of, and I mean, I'm pretty sure that they're very well known and they do very good work at these treatment centers. So it's easy to follow up with them at DRC. It's a little bit harder at these other treatment places. And that's actually something we'd like to start doing. And we're looking into doing that in the future. Any other?
Right. Great. Good evening, everyone. I'm Anjani Joyner. I am an emergency medicine physician, and I serve as the medical director for Durham County EMS. I was a poor stand-in for Captain Helen Tripp, who was supposed to do this on her own. She was actually going to be out of town, but now she's not, so you are blessed with her presence. I'll let her introduce herself.
Captain Helen Tripp. I am the manager of the community paramedic program for Durham County EMS. And I was supposed to be teaching a class, but due to funding cuts, the class got canceled. So I get to be here instead. So I'm excited.
So we're really grateful for the opportunity to share the work that we're doing with our community paramedics and our post-overdose response team, as well as our medication for opioid use disorder program. So our settlement funds that Durham County EMS received went solely to funding 2 additional community paramedic positions. So our community paramedic program was started in, I believe, 2017, before my time with Durham County. And it started with 1 community paramedic manager, Helen Tripp, and 2 community paramedics. And with these funds, we were able to fund 2 additional positions. So now we have a total of 5 CPs, which is great. So we expanded our coverage model from 7 a.m. to 7 p.m. to now 7 a.m. to midnight. So the 2 additional CPs are in the field from noon to midnight, which is huge because most of our overdoses in Durham County occur from around 3 p.m. to 1 a.m. So we have that expanded coverage really adds a lot to our programs. So due to the hiring process, our CPs weren't able to start until February 17th. So the data that we'll be presenting will be kind of from the inception of the program, as well as from the start date of our CPs to present. So a little bit of background information, just to go over the overdoses that occur in Durham County. So this is from May of 2023 to present. And we average more recently about 55 to 60 calls for opioid overdoses per month. So that's about 2 per day. And these numbers are downtrending as we're seeing, across the country, across the state, in Durham County, which is, very good news, but it is still a substantial number that we're seeing and definitely needs to be addressed. So the animations didn't work. Our community paramedic program with respect to opioid use disorder kind of focuses on these 3 priority areas. So harm reduction, treatment, and care needs. For harm reduction, we provide naloxone throughout the community. So similar to some of the other programs that you've seen here today, we provide naloxone to community partners, to law enforcement, fire department, clinics, health systems. And then we also, we don't do a needle exchange or supply exchange, but we are able to dispose of needles and supplies safely for individuals who use drugs. From a treatment standpoint, we provide low barrier access to care through medication for opioid use disorder by providing buprenorphine, which is an FDA-approved medication to treat opioid use disorder. We also will link patients who are started on treatment or even those that are not started on treatment to outpatient programs so that they can continue their treatment. And then we offer bridge treatment as well. So if we start a patient on buprenorphine, we are able to bridge them with continued treatment. Our CPs or a field medic will meet with them every single day until they are established with a clinic for long-term care. And then finally, care needs. So as we've seen, this patient population has a lot of unique needs. And so our CPs really strive to take a holistic approach to their care and to address some other challenges that they may be working with. So we are able to assist with housing, safe housing importantly, so connecting people to resources throughout the community. We are also able to assist patients with insurance. So many patients are not insured, they may qualify for Medicaid. And so our CPs are able to help them set up the application and work through that process as well. And then unmet social needs like transportation, food. So we are able to connect them with community resources to assist with those issues. Our post-overdose response team kind of spans across these 3 areas, and our medication for opioid use disorder is focused primarily on treatment and care needs, but our CPs are able to do all of these activities. So a little bit about the post-overdose response team. So post-overdose response team kind of falls into 2 buckets. So those patients that are seen immediately after an overdose. So this would be a co-response typically with a field paramedic. So this is a 911 call. Field paramedic is on scene and a community paramedic will co-respond to provide that additional assistance. And then we also have our 24 to 48 hour follow-up with patients who have experienced an overdose, were encountered by Durham County paramedics. And then, whether or not they were transported to the hospital, our CPs will still attempt to meet with them in that critical period after their overdose. So again, we do harm reduction through naloxone distribution. Because we are on scene with patients, that offers us a really unique opportunity to provide naloxone, not only to the patients, but also to their family members and to their friends at the scene. And then we also offer the opportunity to engage with a certified peer support specialist. Ideally, our post-overdose response team would have a peer support specialist. We currently don't have one, but that's a really important piece of our team so that we can have someone who has lived experience that can really connect with a patient at a very scary and challenging time. And then linking patients to treatment programs or initiation of buprenorphine in the field. So our CPs can do either of those approaches for our post-overdose response visits. So a little bit about our medication for opioid use disorder program, our MOUD program. So this, our traditional response to opioid overdoses is typically one of three results. So either we encounter a patient who is dead or is in cardiac arrest. Unfortunately, we don't see that quite as often anymore, but it still happens. Alternatively, a patient is transported, whether they're transported to an emergency department or to an alternative destination. We are able to transport patients to DRRC. And then about 25 to 30% of our patients refuse transport on scene. And that's due to multiple reasons. A lot of them have distrust with the health system, or there's fear of law enforcement involvement. So that's a very complex, there are very complex reasons why they would refuse transport. But with being able to offer treatment on scene, this is the definition of low barrier care. So we're able to provide patients who may not otherwise encounter the health system with the opportunity to get started on medication. In 2021, I believe it was, about a quarter of patients who were eligible for medication for opioid use disorder were not receiving it. And this is one way that we can reach this really vulnerable population. So this is our process map and what we follow for our treatment initiation. So typically, we have an EMS response to a patient who has experienced an overdose or a patient who is in withdrawal. And so those categories it may be someone who received naloxone from a bystander and was thrown into withdrawal because of the naloxone dose. Or someone who has not used in 24 hours and now they're in withdrawal. So both of those patient categories would qualify for our program. We still provide our advanced life support treatment through administering naloxone. So the way we administer naloxone is we titrate it to respiratory drive. So we do not try to throw patients into withdrawal because that's really cruel. And it's also a safety issue for the patient and for our providers. So if we encounter a patient who's in acute overdose, that's our goal is to titrate so that they're breathing on their own and they're supporting their own respirations, and we transport them to a hospital for further care. However, if we encounter someone who is already in withdrawal, they're wide awake, they're withdrawing, they're suffering, we can offer treatment. So if they meet the criteria for the program and they agree to treatment, we will start the treatment on scene at that time. And so any one of our paramedics currently can do an induction in the field, a buprenorphine induction. We did that, started that about a year ago, where we expanded it to all of our paramedics. And that has made a huge difference in the number of patients that we see. And then our CPs primarily will do the bridge dosing just because they have more availability. However, if we have a CP who's on vacation or we don't have coverage for that day, then our regular medics can fill in and provide induction dosing, or bridge dosing until they're referred to a clinic. So as per state regulations, we can only bridge up to 7 days, but we've received we've given permission to go longer in extenuating circumstances, often, housing challenges or patients aren't able to get into the clinic that they wanted to go to right away. So we work with people as best as we can. And then we also receive many external referrals. So they don't have to call 911 in order to get referred into this program or to receive treatment. They do have to be a Durham County resident. But we've received referrals from emergency departments, from other clinics, behavioral health urgent care, for example. And then we've had a number of referrals from patients who received treatment and referred family members or friends. And then they started on treatment through that route. And I'm going to hand it over to Helen to go over some of our data.
So this is from the beginning of when we first started doing medication for opioid use disorder in the field. We've had a total of 100 unique patient encounters for that during that time. That's about 1 per week that we're working with. Sometimes those grouped up into like 5 or 6 in 1 week and none for a couple of weeks, but on the average that works out. Now, of those 100, we've been able to successfully refer 75 to facilities in providers in the community, whether that's opioid treatment programs or office-based opioid treatment programs. And 25 lost to follow-up. And what that means is we couldn't find them again. We got them started with buprenorphine, but they didn't return phone calls or something. We just weren't able to get back in touch with them. And that happens, unfortunately. Of the 75 that were successfully referred, after 30 days, 24 were still in treatment, which is also great. 7 not in treatment, but we also see that we also have some problems with missing data. As has already been hinted a couple of times, there are challenges with getting follow-up data from some of our providers. We're working on that. We're hopeful that the future will be able to work that out a lot better, because I really think we probably have a better retention rate than 24. But you know, we don't know that for certain because we just can't find the people, can't get the responses back from the providers to find out if they're still there or not. So of those 100 encounters, we've had 74 unique patients. What that means, you see there's been at least 13 patients that have had multiple encounters, some of those up to 5, where we treated them, we referred them, or we treated them and they disappeared or something, but they came back. And I think that's huge because they came back. When they realized that they wanted to get treated again, they knew how to get in touch with us, but make sure they have all of our contact information, and they called us and asked for bridging again. And so of several of those have finally become successful in their recovery and have stayed in treatment. But we'll take them back. We're happy to do that. Please call us. So of those 74 unique patients that we've had out of the 100 encounters, we've had 54 that were successfully reestablished and 21 lost to follow-up. 24 again retained in care at 30 days. And then we've got the missing follow-up data, of course, as usual. That happens. We're still hopeful that one day we'll figure out how to resolve that particular one. Now, as we said, as Dr. Joyner said, our 2 new community paramedics started in February of this year. And so we've got some data just to see what's happened since they started. And since February 17th, we've had 16 unique encounters. 15 of those were successfully referred. 1 lost to follow-up. 7 of those, 15 were still in treatment. And we had 8 that we don't have data on. We're still working on getting that. And then of those 16 unique encounters, 15 are unique patients. So only 1 repeat patient in the past few months. So this is good. And again, 14 of those were successfully referred. So overall, we're doing well. I'm looking for opportunities, more opportunities to reach out to people, to get into the communities, to letting people know that we're there. We've partnered with NC Harm Reduction. It's great to see Lofton here. Thank you. But we've partnered with NC Harm Reduction, and I'll show you some of the referrals that we've been making. We have great referral opportunities here in Durham. Lincoln Community Health Center by far has been our largest referral partner. And they're very low barrier. And one of the great things about Lincoln is that they do, once the person has completed their intake, they can do walk-in appointments. If they are a Lincoln MAT patient or MAUD patient, they can do walk-ins after their intake. But they also will take care of other health problems as well besides the MAUD. So that's really helpful for patients who have other health problems that they haven't been taken care of because they've been so focused on their substance use and the things surrounding that. You can see Durham Recovery Response Center, obviously, as Lacey was saying a while ago, has been a great partner. Morse Clinic. We've had a couple of referrals from the Justice Services Department. And those were people who had been released from prison and had Medicaid pending and couldn't get their Suboxone because they couldn't afford the copay. So we were able to bridge them until we got that worked out. So that was great, the opportunity to be able to do that. Some declined referrals because people would get inducted and then again, we couldn't find them again, or they just decided they didn't want any more treatment after that. And then self-referrals, a lot of these are people who already have a connection to a provider in the community, but for some reason maybe they used more of their Suboxone than they were prescribed because their withdrawal symptoms were so bad, they used more, so they ran out before their prescription could be renewed. And we were able to bridge them to help them to get to that appointment, to get that prescription filled. So we don't make those referrals ourselves, but we do make sure and follow up that they get to that referral. We want to encourage them to get to that referral. So we'll work out and help them with that. And as Lacey was saying, offering Uber cards, we do that too. We have Uber cards that we get people at least to their first appointment. We've had some when we did a couple others after that, but our grant only pays for the first appointment, so don't tell them. All right. some of the challenges we had, and again, this is not related to the opioid funding, this opioid settlement funding, because we started this program under a couple of other grants. We lost one of those grants in March due to budget cuts, federal budget cuts. And when we lost that grant, we lost our peer support specialist. And you've already heard the importance of having peer support specialists. So that's one of our challenges. We lost that. One of the other challenges, as we've already talked about, is having trouble getting the follow-up data from the clinics that we have. And I don't think it's an intentional thing. It's not like it's like, no, my data, you can't have it kind of thing. A lot of it's there's a concern about privacy and HIPAA and sharing data. We've just got to work around those legalities and those things like that. And then there's also the potential loss of grant support for buprenorphine and naloxone kits. I mean, the grant, we're purchasing those drugs under grant funding right now. And I've seen several reports about this particular grant is might be cut, might be cut, might be cut. We don't know. It hasn't happened yet, but the potential is there. So those are some of the challenges that we're looking at right now and considering. I was like, I have the case stories here. And so we got a few case studies to share with you. One, patient M, who returned to use after several years of sobriety, called EMS 911 for withdrawal symptoms. A Durham County paramedic initiated treatment with buprenorphine and requested a community paramedic to co-response. Typically, anytime an overdose is dispatched, a community paramedic will be dispatched as well, as long as they're available to go. This community paramedic assumed care, inducted the patient, and then worked closely with the patient to establish outpatient care. So we had a successful.
I just had a comment about this one in particular, because they called me for this one. But this was an interesting patient because he had Medicaid, and he didn't think that his Medicaid would pay for buprenorphine, so he was buying it off the street. And so this was a lot of education that our community paramedics provided as well, which I think really made a difference in this patient's long-term care.
And yeah, it's just one of the things that I discovered years ago when I got into EMS, started working here in Durham. Is a lot of the problems that we see can be helped by education, and that's the same thing here. So this case too is patient T, 12 weeks pregnant, requested assistance. She underwent buprenorphine induction and bridge treatment. She finally got established care with a treatment center that would treat pregnant women. And that's a challenge because not all of them do. And so she was able to get a connection to one that did that. And then she was one that did the friends and family, not discount because there's no charge, but the friends and family referral. But, she referred her partner and her parents to us for treatment as well. So us all in the family, and we were able to work with them and get them inducted and get them started on care too. I'm sad to say, unfortunately, that at least one of the parents did return to use, but the other did pretty well, and the partner did okay too. And then case number 3, patient C requested assistance after 24 hours absence from fentanyl. The field crew inducted the patient, community paramedic assisted. This person was really concerned about being evicted from her home and food security. So we worked with the person over several weeks to give them information about housing resources, including eviction diversion, registration with entry point, information on food pantries, etc. We made sure she had Uber card to get to her appointment. And as of May of this year, that person is still in treatment. So that's another success story. So we're really proud of the work that we do, the work that we've been able to do. We want to do a lot more of it. And I think that was probably the last slide, wasn't it? Okay, very good. So thank you. Any questions?
Thank you guys so much. So if this is outside of the scope of your work, please say so, and we can let someone else take the floor. But we know that xylazine is increasingly present in opioids, and I had the misfortune of telling Morgan earlier today that at our drug tracking program, we've had our first sample with medetomidine in it in Durham County recently, and we know that these substances also can have really severe withdrawal syndromes that aren't treated by opioids because they're not opioids. And so I was curious if that is part of the bridging process that the community paramedic program is able to support with, whether it's through like education to most of the places you listed, this is not a problem, but there are methadone clinics where they've never heard of xylazine still. It's a thing that happens. Whether it's educational material or like doing bridging dexmedetomidine or clonidine prescriptions for that. I was just curious, like what opportunities you might have to be supportive with that ongoing problem.
Xylazine is definitely in the community, no doubt. We, as part of our harm reduction post-overdose response, we provide naloxone kits, fentanyl test strips, and thanks to Morgan Public Health, xylazine, because our grants don't pay for xylazine test strips. Probably if we get new ones in the future, they probably will, but the ones we had just don't. And so we've also done a lot of education with our staff about xylazine, which is a partial opioid, actually, kappa receptors, and so it does respond to Narcan to a point, not to the same degree as the others, like with fentanyl or heroin and things like that, but it does respond to Narcan somewhat. You're just not going to get rid of the somnolence. They're still going to be kind of sleepy. Right. Yeah.
And with respect to treatment during the bridge period, we can't do dexmedetomidine in the field, but we just added clonidine to our formulary like 2 months ago, which is really exciting. I don't have a specific protocol yet to treat xylazine for withdrawal. It is in our overall opioid withdrawal protocol, as well as our MOUD protocol. So we have it twice within our protocols, which is great. I'd love to pick your brain more about that because I'm not an addiction medicine specialist. Okay. Awesome. Thank you.
She's becoming one, though.
Maybe.
Any other questions? Yes.
Well, great presentation and great work also to you, Lindsay. All of you. I'm so grateful for the work you're doing. And the fact that there's just so many different entry points for people to get connected to help. In terms of losing the peer support specialist, had you thought about requesting opioid funding for that? Because I think that is very important. We know that that peer support specialists are really one of the key linkages. So I do want to hear more about that. Thank you.
And I think anecdotally, when we did have our peer support specialist on the team, we saw a huge difference, and Helen can probably speak more to that.
I'm behind on my data, but from what I've seen, just glancing at, she started in July of last year, and just the connections that she was able to make, being a peer, being able to talk to people at the level that I can't talk to people at, was huge. And she was able to make connections, but not only that, but she's not. Well, she was fortunate. We were fortunate that she actually had been a paramedic in the past, although not now. So she understood the business that we do, but she wasn't working with us as a paramedic. And so it freed up our paramedics to be able to do more medical care and not have to be doing the case management. She was able to do that and to handle that. So that helped a lot. And yes, we have asked for a peer in the next budget. So hopefully that will work out. Yes.
Well, I'm just going to put out there, maybe we need to do an amendment in the future because this will affects the effectiveness of the program. So.
Thank you. Any other questions? All right. Thank you.
All right, I think that concludes our event and program for tonight. Is there any last remarks or questions regarding any of the strategies? We do have County Manager Hager. You have any last remarks?
Good evening. I just want to thank everyone for coming and partnering in such an important issue. This impacts all of us, directly or indirectly, and it takes all of us to come with community solutions that will serve our community differently and help come up with resolutions, especially during times where there are funding sources leaving us. Now more than ever, we're going to have to be strategic. But thanks to the Public Health Department and all of the partners that work alongside you, I always learn a lot, and I've heard these conversations often, but I just appreciate you. Durham is so great because we do things creatively and often are ahead of the curve, but y'all are always trying to become better. So thank you.
Thank you, Manager Hager. All right, so if there's any other comments or questions, once again, please make sure you guys are completing out the survey that you guys have here, the QR codes. On your way out, there is plenty of food on your way out. So there's a sort of boxes from Chick-fil-A. So please make sure that you, one, sign the sign-in sheet, and then two, grab some delicious food on your way out. Also, make sure you complete the survey. We'll be reaching out